going to put some tissues in those Toomey bags because I really was having trouble keeping it together during that, as I'm sure happened to some of you. Anyway, in the interest of keeping things going, our first panel discussions today is going to be on failure to rescue. And I'm going to introduce each of the panelists and ask them to come up, and then we'll get seated and we'll get started. Our moderator is Dr. Robert Stoelting, who's the president of the Anesthesia Patient Safety Foundation and someone who wrote a major textbook of anesthesia that is my Bible. So, would you come up and join us? And then thank you. Our next panelist is Peter Cox. Peter is a professor in the Department of Anesthesia, Critical Care Medicine, and Pediatrics. He's the clinical director of the Pediatric Intensive Care Unit and the associate chief in the Department of Critical Care Medicine at the Hospital for Sick Children in Toronto. Thanks a lot, Peter. Our next panelist comes to us from Germany. Andreas Hoeft is a professor in the Department of Anesthesiology and Intensive Care Medicine at the University Hospital in Bonn. But, yeah, I'm an ignorant American, sorry. Okay, thank you. Our next panelist is a good friend, Michael Ramsay, who comes to us from Baylor University. He's the president of the Baylor Research Institute and the head of the Department of Anesthesiology at Baylor. Mike, thank you so much for coming. Appreciate it. Thank you. Our next panelist is Andreas Taenzer, another friend, comes to us from Dartmouth, where he's an associate professor of anesthesiology and pediatrics, and he's the director of the Pediatric Acute Care Pain Service. Andreas, thank you so much for coming. Yeah. And our final panelist is another friend of mine, AkkeNeel Talsma from the University of Michigan. I had the pleasure of working with her when I was at Michigan. She's an assistant professor in the School of Nursing and the director of perioperative outcome research at the University of Michigan. Thank you so much for coming here tonight. So, okay, great.
Well, thank you, Mike, and good morning, everyone. I'm pleased to have an opportunity to make a few introductory comments that hopefully will set the tone, set the stage for this failure to rescue challenge number one panel. I think a place to begin is certainly with a definition of failure to rescue. And if I have a way to advance slides, nobody is showing me.
I stole it.
Go Colts.
My bad. We have another panelist, Richard Afable from Hoag Hospital. In my enthusiasm, I missed him. So sorry about that.
This panel is a failure to rescue. I think it's reasonable to at least ask ourselves, what do we mean when we say that? Silber in the early 1990s coined this term. When a patient dies because of a complication, was not recognized in a timely manner or treated appropriately, the death is considered preventable and failure to rescue. And in fact, failure to rescue is a misnomer. It's not a failure of the code team to appropriately resuscitate. It's a failure to promptly recognize. Success of rescue is based upon prompt recognition, notifying the right clinician at the right time. Now, many deaths and permanent disabilities could be avoided if hospitals adopted safe practices. And here we have some terminology that's come into our lingo, patient safety indicators. In March 2011, the Safety Upgrades report listed 4 so-called patient safety indicators, and I'm going to take the prerogative that I have with the podium and moderating this panel to focus on just one of these. and that is postoperative respiratory failure. I'm going to further refine it to opioid-induced ventilatory impairment, so-called OIVI. I've shown you a number of logos there for organizations, both professional societies and regulatory agencies, that have expressed opinions on what we need to do to deal with opioid-induced ventilatory impairment in the postoperative period. Now let me give you quickly just some incidence, risk factors associated with opioid-induced ventilatory impairment. It's estimated that 13 million patients receive PCA annually. Respiratory depression, if you look at the literature, suggests that this occurs in about 0.5%, but the range is rather large depending on how you define opioid-induced ventilatory impairment. Naloxone use is certainly a telling rescue event of a threatening, life-threatening adverse event related to opioids. Improper monitoring is certainly recognized to be involved in many of the opioid-induced adverse events. Now, I submit to you that opioid-induced ventilatory impairment is the poster child for illustrating the gap between what we know and how we practice. We know that opioids produce depression. We think or should know that certainly monitoring would reduce the likelihood that unrecognized life-threatening ventilatory depression would occur, but in fact there is a gap. We don't traditionally, routinely practice that way. Now, I would like to walk you through very quickly how the Anesthesia Patient Safety Foundation has approached this issue of opioid-induced ventilatory impairment and our stance as it's evolved on monitoring patients postoperatively on PCA. We started with a workshop in 2006. The report for that workshop is in our newsletter. The author is my colleague on the Anesthesia Patient Safety Foundation, Dr. Matthew Weinger. And at that time, we emphasized that this is a safety risk. It's a preventable cause of morbidity and mortality. We urged that there be immediate consideration of the potential safety value of continuous monitoring of oxygenation and ventilation. We also felt that monitoring resources need to be directed to those at the greatest risk. We waffled. You're going to see how this has evolved to a different stance over the last few years. Despite these recommendations, in 2009, we recognized that the problem continued to occur. Dangers of postoperative opioids, is there a cure? An editorial by Dr. Weinger and myself, again in the newsletter. All the APSF newsletters are available online. And at this time, we urge that one make continuous monitoring of oxygenation routine rather than the exception. We urge that one assess the need for supplemental oxygen. I never thought I'd say that oxygen was the wrong treatment, but indeed we're beginning to recognize that there are risks associated with oxygen administration, and if it's not needed, we shouldn't administer it. And we at this time also urge continuous or considering monitoring ventilation with technology capable of detecting progressive hypoventilation. And finally, to complete the circle, just recently, APSF, conducted a consensus conference of many stakeholders. No patient shall be harmed by opioid-induced respiratory depression. And we dealt with monitoring strategies. Again, this report by Drs. Weinger and Lori Lee in the newsletter. And here we now are taking, I think, some more definitive stances. Continuous electronic monitoring of oxygenation and ventilation would clearly reduce the likelihood of unrecognized depression in patients. And we looked at the issue of, do you monitor everybody or just those at high risk? What about the cost, the return on investment? And after considering all this, we came away with a recommendation that all patients should have oxygenation monitored routinely by continuous pulse oximetry, and it would be desirable to link this to a patient notification system, with responders being ones who were educated in the pathophysiology of respiratory depression, the pharmacology of opioids, and who understood the risk of threshold alarms, who understood the misleading information that pulse oximetry may give in the presence of supplemental oxygen. There was certainly discussion of alarm fatigue and threshold alarms, but I submit this picture to you as the reason why all patients should be monitored. I think most clinicians in the room would recognize the one gentleman probably has a body habitus that puts him at risk for obstructive sleep apnea. But what about the other young man, the thin marathon runner? Yes, he also has obstructive sleep apnea. So any attempt at risk stratification, we have come down to the point of saying simply is not probably in all terms ethical. There was an observation at the Monitoring Strategies Conference from a CEO of a large hospital association who observed that the question is no longer can we afford to monitor, the question is can we afford not to monitor? And I've put an airline boarding pass next to those pictures, and I submit to you that if indeed opioid-induced ventilatory impairment was equivalent to a commercial airline safety issue, that the gap between what we know and what we do would have disappeared yesterday. Every patient would have some sort of continuous electronic monitoring added to the protocol of their care. Now, I think very quickly I'd like to introduce at least two patterns of so-called sudden death in the hospital or unexpected hospital death. This has been popularized by Dr. Larry Lin, who is a sleep pulmonologist, who makes the point that if you look at this particular pattern of unexpected hospital death, so-called opioid ventilation suppression, you see that indeed supplemental oxygen masks the value of pulse oximetry as an indicator of progressive hypoventilation. And our nurses and our physicians need to be educated to understand that threshold alarms can be misleading, give us a false sense of security. And the other pattern that Dr. Lin describes is that of so-called sleep apnea with arousal failure. And here you see repeated events of obstruction or apnea, a threshold alarming. The patient awakens, takes some deep breaths, or perhaps the nurse comes into the room. The patient's now awake, taking deep breaths. Pulse oximeter is reading an acceptable value, and you have this repeated multiple times, and finally arousal failure occurs and one falls off the edge of the cliff. So again, we need to educate caregivers to understand that threshold alarms may indeed be misleading. Very recently, the Joint Commission has issued a sentinel alert, opioids frequently associated with adverse effects. They again quote this incidence that we've just described of 0.5%, and they note that many causes of adverse events often include inadequate monitoring. Now let me conclude just with an observation on a recent CMS proposed quality measure. This is a quality measure designed for appropriate monitoring of patients receiving an opioid by PCA device. It calls for, we're concerned, intermittent monitoring of pulse oximetry. And I'll show you in a moment the text of the statement that is creating concern, and I hope if you share the same concern, you'll perhaps join me as individuals in commenting to the CMS. This is currently in an open public comment stage. The time frame is fairly short, however, because the deadline for comments is January 17th. But the text that has caused us concern, if you read, is hospitalizations during which the maximum interval between documentation of each of the following parameters does not exceed 2.5 hours during the first 24 hours after IV PCA administration, excluding any interval, and so on. And then they list respiratory rate, sedation score, and pulse oximetry. Our concern is that this means that a nurse could come into the room every 2.5 hours and document those three values, perhaps with a spot check of oximetry. And we feel strongly that this is not safe. This is not what we want to have as far as so-called continuous monitoring. And we're urging, along with ASA, the Joint Commission, and others, that number 3 read continuous pulse oximetry to eliminate any doubt of what we're referring to. Now, let me just conclude with a personal bias and observation. How do I personally think we can close the gap between the issue of knowledge and how we practice? And with respect to opioid-induced ventilatory impairment, I think it's leadership, all the stakeholders, but the very last bullet is the one that I think is the one that's critically important to making something happen. It's your hospital administration, your hospital executives. It's your large hospital systems that control the purse strings. They need to be the ones that call together everyone who works in their hospital and say, we are going to have a policy, and we will agree on what is the best policy. And with respect to opioid-induced ventilatory impairment, if a patient is cared for in our hospital, it includes, as part of the protocol, continuous electronic monitoring. So with that introduction and background, I will take my seat as the moderator of the podium. I have questions to ask my fellow panelists. I'm in the enviable position. I just need to know the questions. I don't need to know the answers. So thank you. Well, I have a series of questions that I would like to pose to you as the panelists. We're on a somewhat strict time frame, but what I would like to do is ask each of you a so-called battery of questions. Some of these are connected, so to try to go 1, 2, 3 down the panel with different questions, I think could be a little disruptive. So if I could start with Peter Cox. Peter, let me ask you, many children's hospitals have now adopted some form of monitoring on all their patients to avoid failure in rescue situations. Since your hospital was one of the first to do this, what compelled your institution to invest the required resources and give them the urgency it needed to be done sooner than later?
Well, we've heard from Joe and many others that a lot of what we're doing about is dreaming for something that is bigger and better for our patients. But what triggered us was really a nightmare. A young girl called Lisa was on postoperative opioid infusion, and she was found dead in bed. She had no other reason to die. This prompted a big review in our institution, which was endorsed by leadership, but really owned by people at the bedside. And out of this review, it was pretty easy to see that we could have avoided this death with appropriate monitoring. Now, she was monitored, but there's this concept that just being monitored is safe. It's not. What we recognized that we had a huge system problem. Not only do you need to have a monitor that's adequate, but you have to have a policy that ensures that the correct patients are monitored at appropriate times, continuously in our case, and this will then drive what kind of monitors you'll actually end up going and purchasing. In our institution, we deal with kids from 1 kilo up to 100 plus, from birth and premi all the way up to 18. And so you want to have some kind of standardized system that doesn't replace the nurse, but is an adjunct to what the bedside caregiver does, is able to allow kids to move around because that's what they do, is accurate not only in the higher ranges so that you can see a drop below some threshold, but is also accurate in our institution where we have a lot of kids with congenital heart disease in the range of 60 to 75 or 80, because you need to pick up when those kids' shunts are blocking as well. So we had a big ask of the technology, but I think we had an even bigger ask of our system, because unless we addressed the whole system by implementing the ability to monitor every bed in the hospital, we would have missed our target.
it seems to be such a common theme that we don't react until there's an adverse event. And we just heard it again from your comments. How did you evaluate the impact of alarm frequency when implementing this continuous monitoring in a previously unmonitored area?
Just before I answer that question, what really struck me about a lot of the slides that you've just shown us is that they're from the last 5, 7 years. What I'm talking about is 1998. And we implemented the ability to monitor every bedside in, and I'm sure I can be corrected if I'm wrong, but I think it was the year 2000. So that's how long we've been doing it for. In terms of false alarms, I think one of the biggest challenges that at that phase monitoring brought us was that as an ICU physician and an anesthesiologist, we thought we'd take a monitor out of the ICU, out of the operating room, and put it on the ward, and bingo, you have your answer. It doesn't work like that. What we did was we used a long implementation phase with a lot of education driven by bedside caregivers to educate them what ranges to set the thresholds at so that the monitors would minimize false alarms. And then with each alarm, we had the ability to page a nurse or a caregiver, but that nurse or caregiver did not have the ability to silence the alarm on the pager. They had to go and eyeball the patient. So you wanted to make sure you minimized false alarms. And it was really through a matter of education and buy-in that we actually achieved that. Did we do a before and after study? No, because we were already tainted by what had happened before. But I can tell you that in our institution, it is not a major issue that false alarms are a problem.
One more question, I'll let you off the hook. What lessons should hospitals caring for adult patients instead of children take from your experience?
I think what was important for us was that we needed to understand why we were monitoring someone and what we were looking for. Just putting a monitor on everybody doesn't work. And I think, again, getting back to some of your slides, any kid who's on an opioid infusion or even getting intermittent opiates is obviously someone who needs monitoring. A kid who comes in with a Colles fracture of their forearm and is just waiting on the ward to go to the operating room without any analgesia prior to going does not need monitoring because you're going to tie them down. So it's an active process on the part of the clinical caregivers to decide which patients are appropriate because, again, dealing with kids, you can't have them monitored from the minute they hit the front door until they leave because then they're going to go home to nothing. So you have to have an education of caregivers and families to make this work the way you want it to.
Thank you. Very insightful comments. Can we move on to Andreas Hoeft? And now that we've established you're from Bonn, do you see any differences between failure to rescue in Europe versus the U.S., Andreas?
Well, should I say no and yes, or yes and no? Well, first of all, Europe is very diverse, much more diverse than the U.S., and we have some low resources countries which have, let's say, other healthcare problems or additional healthcare problems. On the other hand, I think there is no difference, let's say, in the normal resources or richer countries. Pretty much the same, and we just did that surgical outcome study, which was published in Lancet last year with Robert Pierce as the first author, and we saw that we have a much higher mortality. The stunning observation was that much more patients die on the normal ward and not on the ICU or in intermediate care. 85% of the patients, regardless whether in the low or high resource countries, die on the normal ward. I would have expected that deadly sick patients would be on an ICU, but they are not there. So this clearly indicates the magnitude of failure to rescue. We had a mortality rate in that study of close to 3% in average all over Europe of surgical patients. We do have, for instance, in Germany, 12 million surgeries a year. So that mortality rate means something like 400 to 500,000 patients per year. 85% of them die on the normal ward. And this is not all metastatic cancer. And my gut feeling is half of those are failure to rescue. So we are talking about 250,000, 300,000 patients in Germany alone, which are possibly failure to rescue.
I'm intrigued by the observation that complications among hospitals often are very similar, but in fact the outcomes are better in those hospitals who rescue more frequently, who are more
That's a paper by
adapted.
Gaffery in New England Journal who has demonstrated that perfectly. And that is why I think that we can really make a difference in that area. That there is something to win for the patient. And I disagree with Joe. It does not need to take 7 years, 5 at maximum.
Now let me ask you, Andreas, could an argument be made that all patients in the hospital should be monitored? Isn't it true that some deaths are in patients who would not be deemed to be at risk?
Yeah, well, I think it would be ideal if every patient would be monitored, but I think that there are clearly risk groups or patients at risk which should be monitored preferentially and as soon as possible. The question is, I believe if we would be a little bit more modest and say we identify clearly the patients at risk, which would be all patients with opioid therapy or PCA, of course, and there are other risk factors, I guess that we can identify preoperatively, so that my estimate would be 20 to 30% of, and I'm looking on surgical patients now because that is my area of expertise, being an anesthesiologist, 20 to 30% might need monitoring. But with those, I guess I would believe we can save 95% of preventable deaths.
Do you agree that all patients receiving PCA opioids postoperatively should
Sure.
receive monitoring?
Actually, this is policy in my hospital, but of course.
Let me ask you, I guess, a related question. How should we consider cost in addressing these known and addressable patient safety issues?
Let me be provocative.
Can we print a platinum coin and solve it all?
No, let me be provocative. We shouldn't consider cost at all. No, more seriously. Yeah, Joe, I understand that you applaud, but no, more seriously. It boils down to an ethical and finally to a political or social political question. How many resources is a society willing to spend on health care? So, of course, give you an example. It would be ideal we would put a nurse next to each patient to the bed. Nobody can pay that. We might have more intensive care and intermediate or IMC intermediate care beds. We can't pay the personnel. So there needs to be a technological solution, I believe, for patient safety in the future. And costs should be secondary. I'm not saying costs are irrelevant. Okay, we should choose a cost-efficient technology to save the patients. But at the end, it's an ethical and a political question.
I think it is a dilemma to deal with what seem to be obvious safety solutions and whether you should have to deal with the cost implications. And I think I've come around to really feeling that with respect to opioid-induced ventilatory impairment, monitoring the cost is not an issue.
Well, cost and cost efficiency is a very difficult topic, and the answer is different, in particular in Europe, between countries. It very strongly depends on your reimbursement system. To be a little bit cynical, the most cost-efficient way would be what we call in Germany sozialverträgliches Frühableben. I translate that. That is socially compatible early death. Oh. That is most cost-efficient, isn't it? But of course, this can't be the solution. So I'm a little bit, let's say, reluctant to discuss costs at all. We have other goals, don't we?
Yes, thank you. Michael Ramsay, can we move on to you?
Yes, Bob.
Michael, would monitoring mandates as so-called official hospital policy be more effective, you think, than individual physicians or groups making these changes?
Bob, I don't know how you can mandate what we're talking about here today in terms of patient safety. It's much bigger than that. And Give an example, at Baylor in 2009, we had 41 rapid response team calls on 2 floors in the month of June. 41. And all of those were respiratory failure from opioid overdose. It was the orthopedic surgery floor, a lot of pain, and it was the gyn oncology floor where there was a lot of sleep apnea. And so we pulled together a team. We had to make a difference. And we got nursing leadership, physician leadership, and administration, and we called it the Breathe Team. Why the Breathe Team? Because breathing is good. Breathing is what it's all about. And the Breathe Team still continues today. But we looked at many different aspects. There wasn't one silver bullet to how to fix this. We looked at education, talking to the physicians about opioid prescribing. Did you know that morphine has its peak effect in the brain an hour later than the blood peak effect? So you're going to get this delayed effect. So be careful when you're prescribing drugs like morphine or hydromorphone. Who's at risk? Well, basically everybody's at risk. But we put a screening tool in for everybody coming in for surgery. Frances Chung is here today. She developed this OSA screening tool called Stop Bang. Every patient gets screened. And they get a little blueberry wristband because now everybody knows this patient's at great risk for opioid-induced respiratory obstruction. So we put in multiple different aspects into the care of the patient, from communication, education, to technology. So it's not just one mandate, it's everybody's got to get involved. We've brought it down now. Last month we had 3 RRT calls. We're not perfect yet, but we're on the road.
I sense that you're a little reluctant to use the word mandate, but do you see any way for this to occur without ultimately it becoming a policy that everybody who cares for a patient in that hospital follows?
Well, I think I got away from saying like one mandate. We actually, in this education process, came up with multiple different mandates. For instance, we stopped continuous PCA. If you're opioid naive, you cannot get a continuous PCA in our hospital anymore. We had 50 different sets of post-op opioid orders. Every surgeon had a different set. We now have 1. So we did actually multiple different things, but they came out of the Breathe team.
Good. Let me ask you this, Michael. Transitions in care and handoffs are certainly a major issue in hospitals today. What are the challenges in your mind, for caring for patients during this transition of care?
I think you go from an intensely monitored recovery room to a floor in most surgical patients. And suddenly you're going from 1 to 2 nursing, good monitoring, to, in many floors, no monitoring. The nurse may come in once every 2 hours. And that's inadequate. Plus, the information that goes from the recovery room to the floor is not adequate. I mean, we have discharge criteria, Aldrete score of 10. This patient's ready to go. But this patient got hydromorphone 20 minutes ago. 20 minutes on the floor, they're going to have a respiratory arrest because that drug has just peaked. And so we've got to have much better communication between who needs to be monitored, what's the status of this patient, who's at risk, everybody's at risk, who's at high risk. So the blueberry armband, a wristband goes up there, the nurses know who's more at risk, who doesn't go back to the floor, who goes to the monitored floor. And all this is related to communication, and communication is the key.
Communication equals education, and
Yes.
trying to make sure that all of our colleagues recognize some of the things that I think we're all saying. That you have to understand the pathophysiology of ventilatory depression. You have to understand the role of supplemental oxygen and perhaps masking the true value of some of our electronic monitors.
Exactly. One of the things we put in place is actually an oxygen withdrawal trial. We will not let a patient with normal lungs go back to the floor on oxygen unless they've gone through a withdrawal trial. And if they desaturate when you take the oxygen off, why do they desaturate? They've got normal lungs. The only answer is they've got respiratory depression. Get them to take a deep breath, they'll sat up. That patient does not go back to the floor. That patient waits until they pass that trial.
I think in a sense you've touched on this, but let me ask it perhaps in a little different way. Could you share with us your experience at Baylor in preventing adverse outcomes by continuously monitoring patients?
what we've done is to provide monitoring for the post-op surgical patients who are going to be on opioids, but it's not just a monitor. Somebody's got to monitor the monitor. And so we've closed the loop in the fact that not only are the patients being monitored, but now the monitor, when it fires off, is going to page the nurse, go to room 310. If the nurse doesn't respond immediately, it's going to escalate. It's going to go to the supervisor. Somebody has to respond. So it's not good enough just to monitor a patient. The monitor's got to be monitored, and it's got to be responded to.
This is, I think, the so-called notification system.
Yes.
Let me ask you one final question. Why do you think that so many of us, perhaps nurses in particular, have such a hard time accurately measuring respiratory rate?
I think, this is a bugaboo of mine, but I think respiratory rate is the most neglected vital sign. It's not monitored. You look at most charts, you'll find a gap on that little spot for where respiratory rate should be, or you see 16. Everybody breathes at 16. It doesn't happen. And yet, if the respiratory rate is above 24, there's very good data to say that within 24 hours, that patient will undergo a critical event. If you've got opioid respiratory depression, the respiratory rate is going to be below 10. So respiratory rate should be monitored. It's not monitored automatically, and I think that's the reason that it's not done. And I think a nurse at the end of the bed, we just heard about one-on-one nursing, the cost of it. I don't believe a nurse at the end of the bed can tell the difference between narcotized respiratory depression and someone in normal sleep. I think observing the respiratory rate is not good enough. You've actually got to listen. Remember the stethoscope people used to have put in their ears? And that's what you need. You've got to hear air movement. And that, I think, is why technology's got to take the place. I think technology will be better than the human.
Good. In an ideal world, how long, if you were counting respirations, should you count them?
Ideally,
So in 15 seconds and you multiply it
you
by
multiply
4.
by 4, yes. But I think you've got to do more than rate. You've got to actually listen to air movement. You've got to know that this patient is moving air. And they can have a respiratory rate of 20 and not be moving air.
Thank you. Andreas Taenzer, can we move on to you? Andreas, you've published what might be the only study that shows continuous monitoring reduces adverse outcomes in post-surgical patients. Could you summarize your clinical results for us and suggest where we might go with notification or surveillance monitoring?
Bob, if I may, I'll just take one step backwards and explain on why we arrived at monitoring all our patients now all the time. There are two reasons. One is that if you look back at the charts of patients who had an arrest, is that they have signs of deterioration over the 6 to 8 hours prior to leading to that arrest. Okay? And the other reason is, and I'm differing a little bit with Peter and Andreas on this here, is that if you look at publications from Australia from 2010, in the rapid response literature of identifying all patients who had a rescue intervention, and then ask experts after the event on if they would have monitored those patients specifically, they agreed on exactly 50% of patients. It was a coin toss. These were ICU physicians. So we came to the very humble acknowledgement that we as physicians, as care providers, are not able to predict who's going to have an adverse event or not. That's Leah, right? It's a healthy girl coming to the hospital for a procedure, moderate risk. She dies. So it became clear to us that we wanted to monitor all patients all the time. We started to do that in a unit where we had the most problems, a 36-bed orthopedic unit. And our outcome variables were twofold. One were rescue events, and the other outcome variable was unanticipated ICU transfers. We put everybody, every single patient on the pulse oximetry network who came through for 12 months, compared that to the 12 months prior. 97% of our patients actually had the probe on during that time. We reduced rescue events by 65% on that unit in those 12 months when we were monitoring, and we decreased unanticipated transfers to the ICU by 45%. Since we implemented this system, in December 2007, we have had no death and no hypoxic brain injury from respiratory cause in that unit. So maybe there is some sort of an answer coming up now for you. Our institution, based on these results, expanded continuous monitoring to all surgical floors, to all medical floors, and to the pediatric floor. Talking about mandates, at Dartmouth-Hitchcock Medical Center, we mandate that you're continuously monitored unless you're in direct contact with the care provider. And if you don't want to be monitored as a patient, you have to sign a waiver form. So where does patient surveillance go? That's where we are today.
Were you? I'm the hospital administrator now with having to control shared resources. Were you able to show the hospital that there is a return on their investment in a positive way with this continuous monitoring of every patient?
Well, first, just like all my other peers, call into question the question of cost, right? I mean, we know code teams are not cost efficient, yet we have them, right? There's some ethical mandate at times to do the right thing. Coming back to your question, we saved money from the first year of implementation on. And the way we measured it is, and cost measurement in hospitals is a nightmare, but in the 12-month that we monitored compared to the 12-month prior where we did not monitor, we had 150 patient ICU days less from that single 36-bed unit than we had previously, and then we basically repeated that exact result when we expanded to other surgical units. So 150 ICU days, I won't give you a dollar number, but if you think about your own institution, what the cost benefit or opportunity at least may be of 150 patient days in the ICU.
Let me shift gears just a little bit, Andreas. For those who want to monitor ventilation, what are your thoughts about end-tidal CO2 versus respiratory rate for continuous monitoring?
So, first of all, we don't have the tools to monitor ventilation right now on patient who breathe spontaneously in general care areas. Respiratory rate doesn't do it, pulse oximetry doesn't do it, and end-tidal CO2 doesn't do it. If I look at it from a patient's perspective in the general care area, whatever we monitor, it's only as good as that monitor is tolerated by the patient. End-tidal CO2, I can't even keep that on in half-asleep patients who are somnolent in my recovery room, right? Respiratory rate works very well, but we have about a 25% refusal rate. Pulse oximeter, I can get on anybody. So to answer your question, it's not end-tidal CO2, it's not respiratory rate. If I have one monitor, it's pulse oximetry. Because the end of all badness, of anything that happens to our patient, the common pathway is at some point, the oxygen saturation goes down. And I rather want to know about it than not know about it.
Thank you. AkkeNeel, can we move on to you, please? How do nurses need information about their patients presented to them?
Well, first,
In 60 seconds or less.
First, I'd like to thank Joe Chiani and Dr. Michael Riley for bringing us together for this inspiring conference and to have us all come together and work on the goals that we set out to create safer healthcare and patient outcomes for all of us. So nurses are the largest workforce out there, and so we're all touched by it one way or another. This puts onus on nursing, and I would say with that the physician assistants and the hospitalists who also now are oftentimes staff and contributing to these efforts. We need to have the right information to make the right clinical decisions, look at trends and patterns, and some of these complications we've talked about today, they're not clear at first. It might take a couple days of couple data points to look at before we understand that we might have somebody heading in the wrong direction. We have many, many data points from many, many companies put into either paper medical records or in electronic medical records. And we find oftentimes that we need to put something on top of that to pull in the right information so that we can make the clinical decision that's necessary to care for this patient. So I hope out of this conference that we all start getting together to put the right pieces of information together so that our nurses and all other clinicians can have in one hand a checklist that we need to complete, and on the other hand have the clinical data for this patient for the past 24 hours, not only respiratory care, but other components as well that will be used to make the right clinical decision.
Very good. Let me just follow up a bit with that then. Can you provide perhaps some examples for nursing staff when continuous monitoring is instituted or implemented in a previously unmonitored area, and how should this be addressed proactively by the hospitals?
Well, one project I've worked on was where we used these data elements to prevent pressure ulcers, and we looked at length of stay in ICU, duration in the OR, we looked at vasopresses, and with that information, the nurses could make, during rounds, a very good determination whether the patient might be sliding towards a pressure ulcer. Having that information in hand, they could then take active initiatives and help prevent it, and we were able to demonstrate impact. We used the same technology in the ICU to help prevent ventilator-associated pneumonia, so we're very effective. We also used that kind of approach with implementing preventive measures. So these approaches so far I've worked with have been successful being targeted. I'm concerned if we have continuous monitoring of everything that we're back to being flooded by many data points, not having the information we need to make the clinical decisions. So I would urge the industries and the experts to find out what are the critical pieces of information we need to make the right clinical decision without flooding ourselves again with the information or the alerts, because we all have heard about alerts nobody responds to. We all have been in a hospital hearing every possible alert going off and nobody walking one step faster. So to me, that's a piece we need to get rid of, but we do need to have the right data in front of us to be actionable. And one area I think we might want to move into is the emergency room. When I did work on failure to rescue, we discovered that many of these complications sometimes are latent, are already present, and could be detected as patients showing up in the emergency room. So I would argue that we maybe on the front door do a better job to pick up on anybody who might have a complication coming down the line that could cause a lot of trouble later on.
Very good. I've read recently that ECRI Institute has identified the incidence of false alarms as a true patient safety issue.
I would agree with that.
And we think we all need to address that in some way. Richard, can I move on to you? As a CEO of a healthcare system, how are governance boards and administrative leadership now looking at this issue of failure to rescue?
Well, let me also echo the sentiment of compliments to Joe and to Massimo for bringing us all together in this quite expert panel here in this particular subject. For me, as a hospital administrator and prior life as a physician, failure to rescue is one of many clinical imperatives that need to be addressed and need to be addressed by those who are in the most significant position of allocating resources, which is, now you may think that I'm going to say hospital administrator because you already threw us under the bus.
Yes.
When you put that slide and you had that last bullet. And you might actually think it's going to be the board, but it's actually leaders. Peter said it well this morning. Leadership is what will drive the imperative around the clinical requirements of care. And failure to rescue is one of the most important issues in the hospital setting. It's not the only issue. As it relates to leadership, then, there is no doubt that governance is leadership. And for those of you who might be unfamiliar in the room what governance means, it's essentially those individuals who are most responsible for using the resource known as a hospital. And for those individuals, they have to be able to know what the goals are, but they also have to have the capacity to move resources to achieve those goals. And the common mistake, I'll try to get practical here for the moment then, the common mistake that physicians or department chairs make is that they move forward with goals that are personal to them, but not amenable to what it is a particular organization, whether it be a university or a hospital or whatever it might be, needs to achieve based upon its mission. And so if it's the Department of Anesthesia needs X, then that's a resource allocation decision. If it's people are in jeopardy and in danger, and we have a way to affect that, and oh, by the way, if we do this, we can acquire that, we can move in that direction. That's a very, very different conversation for leaders and for the allocation of resources. One of the things we did at Hoag, and just a little bit about Hoag, Hoag is your classic community hospital. It's the 11th largest hospital in California, non-academic setting, classic 500-bed community hospital. One of the elements that was important to me as I came on as the chief executive at Hoag some years ago was my board was incapable of making those kinds of decisions because they were local business people, they were local community members. They couldn't make a decision like that. And so they were very much dependent upon getting as many opinions, and the problem, of course, is that the opinions all varied. One of the things that we did very early on is we changed the board. And so now I have board members who have the capabilities to make good decisions around resource allocation based upon reasonable information. And if you don't have that, it's going to be very difficult to make good decisions as it relates to resource allocation. Now, with the capacity to be able to make those kinds of decisions. And so who did we get? We got the CEO of a robotics healthcare company. We have the CEO of an IT company. We have the CEO of a large group purchasing organization. We have an ex-CEO of a health plan. Those are the kind of individuals now who are in this community hospital board. And the point to be made is that they can now make good decisions. That being said, I can say, again, being practical for a moment, there is no proposal from a group of clinicians that a board can deny if presented in the right way. And your look of surprise proves to me that you don't understand that that can happen. The point is, I advise my physicians all the time on how to give me proposals and how to make it compelling and real, and thus things that we can do. Now, the trade-off is, if I'm going to allocate a resource on continuous oxygen monitoring, unless I have unlimited resources, I'm going to have to pull back a resource someplace else. And we're going to make that as a group decision. Governance as leadership, understand that proposals made to governance should be done in a way that is consistent with the mission of the organization as opposed to an I want, and make sure that governance has the capabilities to make those decisions well, as opposed to relying on resources that may not be amenable to the issue at hand.
Thank you. Let me ask one final question then, Richard, if I can. Again, as a physician and a CEO, what other types of failure to rescue situations do you see being a problem in hospitals other than the respiratory depression that we've given so much attention to?
Right. Well, respiratory depression is an important issue at hospitals that do many procedures, especially surgical procedures, and we already heard that. One of the issues that is a big concern at our hospital is postpartum hemorrhage, because we deliver in excess of 6,000 babies at our organization on an annual basis, and occult bleeding and failure to identify early is a significant issue. The technology is now moving us in a direction where we can do a better job at monitoring that. The Q6-hour hematocrit is, it's like diabetes. It's like taking a blood sugar, giving insulin to drive the sugar down, right? So it's making insulin work backwards. Same thing with bleeding. We need to be able to have predictive capabilities around hemorrhage. So for us, respiratory depression, sepsis, and hemorrhage are three areas that we're focusing on failure to rescue. And allocating the resources, showing the potential of the results that can come from that, goals that are consistent with our mission.
Thank you. I think we are out of time. I'm out of questions. I would like to certainly thank my panel members for their responses and answers. I hope you as the audience have found this to be a useful session. So thank you for your attention.